So, a big question about depression and anxiety is actually what causes it. And at the end of the day, we don't fully understand because there are so many pieces that work together that can contribute to someone's risk and presentation of depression and anxiety. So there's these three kind of theories. None of them are that great, but it's good to talk about them so that there's an understanding of why we use the medications that we use, why we approach these conditions the way that we approach them. So the first one is the monoamine hypothesis, which essentially is based on the mechanism of action of our early antidepressants. And actually, antidepressant effect was coincidentally discovered in an anti-infective where they used it and people's moods improved and then kind of reverse engineered the product to determine that monoamine oxidase inhibition, which is an enzyme that breaks down monoamines, which are a lot of our neurotransmitters, actually improves mood. So our old products increase the availability and levels of norepinephrine, serotonin, and dopamine, which they go, oh, okay, we just need more neurotransmitters. However, if we actually look pharmacologically at the mechanism of antidepressants, say you take a dose of sertraline or Zoloft, right? This is a selective serotonin reuptake inhibitor. It causes the availability of serotonin to be increased the first day that you take that product. But we know that these medications can take 3, 4, 5, 6, 12 weeks to fully work. So clearly there's more going on than just, oh, if we make more serotonin available, then people feel better. Boop. So what else do we think? Okay, well, maybe it has to do with the receptor sensitivity. So if you make more serotonin available, there may not be enough receptors on the neurons to actually use all of that serotonin. So there has to be this upregulation, this change in the amount of receptors that can actually interact with the serotonin or the dopamine or the norepinephrine. Maybe this might be a bit of a component to it. It's very difficult to know because it's not easy to study the amount of serotonin receptors that are in everybody's brain's neurons, right? So we can't really reproduce this. It does kind of talk a little bit to the delayed activity, but it's hard to know for sure. So then looking at it more holistically or globally, there's the monoamine hypothesis of gene expression or the stress model. So remember I mentioned corticosteroids, stress hormone affects the HPA axis and can cause changes in the brain's sensitivity and what we call neurogenesis, which is part of neuroplasticity. So that's creating new connections, removing old connections. So when we postulate that individuals can have normal amounts of these neurochemicals, but they just the actual system, the connections just are dysregulated. So depression as well as stress cause that cortisol increase, and that actually suppresses a really important factor called BDNF or brain-derived neurotrophic factor. And when you suppress that, you're going to see less neuronal growth. And we actually can see the hippocampus in particular will atrophy. There's less strong connections being created and people don't feel good. So when we increase neurotransmitters, particularly serotonin, but other things like glutamate, for example, it'll enhance the effects of BDNF and will promote neurogenesis. So we see that there are a number of different factors that can potentially play a role. Of course, there are genetic factors that influence the pathophysiology, and everyone's experience of a mental illness can be different because how the brain atrophies or how the brain forges new connections may be quite different. So one person, it might be related to their balance and regulation of dopamine, but the other person, it's norepinephrine, or it's both of those things. And unfortunately, we don't have a great test yet to determine exactly which types of antidepressants or which types of pathologies are contributing to every individual's depression in a way that is simple to reproduce and reliable to describe. So when we look at anxiety, anxiety is challenging in that there's a number of involved systems that seem to play a role. So when we think about fear and anxiousness, if you're in class, you remember the limbic system and the amygdala. So the amygdala helps to process memories. It sort of acts almost like a relay into the hippocampus. And like I had mentioned before, the hippocampus starts to shrink. It's not working as well if there's excess stress. So it's a stress system dysregulation. So this is influenced by so many different systems, neurotransmitters, receptors, etc. Right? So we have norepinephrine, serotonin, GABA or gamma aminobutyric acid, corticotropin releasing hormone, which is part of the stress hormone system, and the HPA or hypothalamic pituitary adrenal axis. And all of these things, if dysregulated, can cause symptoms of anxiety. So looking more specifically, when we think about response to threat or stressors, because anxiety is beneficial in a lot of ways. Feeling anxious can help provide the appropriate fight, flight, freeze, or appease response in the face of a threat. However, some individuals' ability to kind of reality test or to be able to assess those threats as actual threats versus not really a threat can become dysregulated. So in response to a threat or a stressor, we have a space called the locus coeruleus, which is something that will stimulate the release of norepinephrine. And norepinephrine essentially will help to work in modulating arousal and functions that can really downstream affect a number of different physical symptoms as well. So if someone is chronically stressed, the locus coeruleus actually can become oversensitive or hypersensitive to stressors. So then we see anxiety-like behaviors. And when you use something called an anxiolytic, so a medication that acutely decreases anxiety, we also see a suppression in the activity of the locus coeruleus. When it comes to GABA, GABA is our primary major inhibitory neurotransmitter, and it provides a regulatory effect on serotonin, norepinephrine, and dopamine. And when we increase the utilization or availability of GABA in the brain, we see a decrease in anxiety. Okay. So increasing GABA will decrease anxiety. And then serotonin. Serotonin is probably one of the most complex neurotransmitters. And when serotonin is present in a specific area of the brain called the raphe nuclei, it acts as an inhibitory neurotransmitter. So it has a calming or, tamping down the nervous system effect. And there may be some dysregulation in the function and or reuptake and utilization of serotonin, possibly particularly in that raphe nuclei. So what does all this mean? It means that we don't know, but there appears to be some level of dysfunction in our frontal cortex, in our limbic structures, right? So the limbic structures talk to the frontal cortex, right? So if you remember the nucleus accumbens, the ventral tegmental area, all of that stuff that has to do with things like reward. It talks to the amygdala because of some of the negative rewards, particularly if you think about substance use disorders. And that informs the frontal lobe or the frontal cortex for things like concentration and executive functioning and decision making. But when we manipulate these systems, we can alter depressive symptoms. How this works, we don't fully understand, and it seems to be a little bit different from person to person, thus some of the challenges that we have in our approach to treatment, which we will talk about in the next video.